We're here at Advanced Neurosciences Institute in Franklin, Tennessee at a NeuroNexus event. Thank you so much, Dr. Jonathan Cockwood and Dr. Sam Hunter, for joining us. I'm Dr. Daniel Cantor, and we're going to talk about a tough topic in multiple sclerosis. Does MS burn out? What do you think, Dr. Cockwood?
Yes, a tough topic, very controversial. We've had this knowledge of the aging immune system for some time. As we get older, our immune systems gradually fade. And the notion is that an autoimmune disease should gradually fade as well. MS, however, is very peculiar. It appears to be very inflammatory early on, and our treatments that we have are very effective at controlling inflammation, relapses, MRI changes. But when people get to a certain age, do they really need these treatments? And that's a huge question, and there's a huge research gap. Most of our early research in MS has been focused on patients between 18 and 50 or 55. And outside of those ages, we don't have a lot of rigorous, well-controlled research data. So this has led to this kind of wild west of people, sort of neurologists and patients, kind of doing whatever they think is best for them, not based on any knowledge or information. I would just like to urge caution about this, in that not having data in older people that the treatments work is not the same as saying that the treatments don't work or aren't needed in older people. So for me, it's a case-by-case decision, patient by patient, understanding and educating the patient, because they might have been impacted or influenced by something they read on the internet or somebody's opinion, a physician's opinion, that may not be based on data. Right now, we have to base on our experience. There are smaller studies here and there that do seem to give some clues, but it's kind of like, which study do you want to believe, simply because there's a lot of contradictory data that's out there. So for me, it's a difficult decision. I tend to not discontinue treatments simply because someone's reached a certain age, but rather look for those factors in that individual. Has there been any change? Are they worsening? Is the disability changing? If they are they worsening because of MS, or are they worsening because these are older patients? A bad knee, a bad ankle, a bad hip, they're not walking as well. There's all these other comorbidities, or the impact of physical deconditioning, just being out of shape, can look like progressive disability in MS. So caution on two fronts. One, let's make sure they're really progressing for MS. And then two, have a conversation, frank with the patients. Here's what we know, here's what we don't know. What do we want to do?
Dr. Hunter, does MS burn out?
Well, data helps a lot for an individual. And there are people who go extended periods of time with absolutely no evidence of disease activity. And by that we mean any change with careful look and compare with MRI, which most people unfortunately don't get, and with careful regular assessments that let you detect new events. Because patients don't appreciate all their disease activity. This is for sure. In fact, the majority of disease activity they're oblivious to. If you see disease activity, you can be assured it's going to continue when you stop someone's treatment. That said, there are people who get to an older age and have had no disease activity for a decade or more. I'm pretty comfortable saying that, yeah, we'll watch you off treatment. We'll watch you closely. Experiments have been done with this, all right, in terms of looking backwards at how people have done, which are not as good as looking forwards with experiments. But looking backwards, about 40% of people have disastrous increases in disability when they've been stable at least 5 years and their treatment is stopped. Now, you can look at this as the glass half full. Hey, half of them did fine. But the other half, it was a disaster. And just like you wouldn't put less players in the game in the fourth quarter than you need to defend your goal, you also, I think, shouldn't back off your treatment if there's any evidence that that's going to create a liability in the future for treatment that could put you so behind the ball you never catch up again to where you were before. That's the danger.
Dr. Kanner, I'm curious about your approach to this as well. When you do discontinue treatment in an older person, what's your approach for monitoring them for recurrent disease? Do you have some kind of way that you address that situation? How do you, what do you educate the patients about to look for? Do you monitor them in some way, or what is your approach to that?
Well, on the one hand, it makes sense that MS could burn out because we think of the immune system as being less active as you age. On the other hand, if MS is not just about overactive immune system, instead it's about dysregulation, the question is, does that dysregulation burn out just as much? And one of the problems is that we've all seen people who have multiple sclerosis who have said, oh, you're stable, your MS isn't active anymore, we take you off of your disease-modifying therapy, and then they have a very large relapse. And that's been troublesome for clinicians because we see that and then we're like, well, now we don't know what to do. And that's why, even though there are studies ongoing and some of those with governmental funds looking at the idea of stopping therapy, doesn't matter what those studies are going to show, we're still going to have that question in front of us on an individual patient. Now, it happens because of insurance reasons, because of coverage reasons, because you decided as the clinician, or because the patient decided that people come off of therapy. And then it's important for people to continue to be monitored clinically in terms of their history. Is their history changing? To be monitored in terms of their physical examination. Is their physical examination changing? And then our other form of monitoring is going to be an MRI. And it used to be that we were all part of consensus panels that had no consensus on how often MRIs are happening. Now it looks like more and more people are talking about this idea of an annual MRI, at least for a certain period. The question is, does it make sense later on? Well, I think it certainly makes sense if you're going to pull therapy away to continue to monitor the MRI, to make sure that the person isn't having more activity that you're not seeing on a clinical basis. And so I have those sorts of discussions with people with multiple sclerosis, and I also inform them that they're taking a chance. They're taking a risk. You take a risk when you go on therapy, but you also take a risk when you come off of therapy.
Dr. Hunter, how do you do it when you discontinue treatment in some
Well, first of all, I like somebody who doesn't have a lot of disability because the liability when you have somebody who's just barely walking or barely independent and all it's going to take is a little bit more to do that. I like to see 10 years of no disease activity. I'm usually confident if I have those records and I have those pictures. The one thing that's hard about MRI, while MRI is a very good indicator of disease activity in younger people, in older people it is not, because the inflammation changes. It's kind of like, MS is kind of like an occupation of the brain. And once it's sort of been occupied, it just slowly consolidates the areas. And so these changes are very small, and if you look at them as a picture, you may say, oh, it's not any different. But if you get out a ruler, it's like, well, it's getting worse all the time. And we know this from studies that have been done carefully in the brains of people who passed away with MS. What used to be thought is MS burns out. And what actually is the facts is it's still active in everybody. It's just a different kind of inflammation. It's this very insidious, we often call it smoldering, inflammation at the margins of the worst old lesions. So what were the worst problems are often still getting worse. So what can you do? You look at them clinically. We have some very careful new ways to do that. We measure their mind, we measure their hands, we measure their walking, we can measure their eyes in much more confident ways and actually look at what's changing. People who are really changing often don't appreciate it. If you have a lot of disability, you feel more disabled only if it's a major change. I mean, if you've never walked right for the last 20 years, you know, it has to change quite a bit before people really say, hey, you know, I'm doing a lot worse. And so you don't appreciate small changes. I've even had people come in who are in wheelchairs who can't lift their arms, and I'm like, when did this happen? And when you pin them down, well, there was something that happened 4 or 5 months ago, and it's like, why didn't you come to the doctor? And it's, well, you know, we just thought it was MS and it would get better. And it didn't, you know, and this happens. And you know, hindsight's 20/20, as we love to say in medicine. And I think that's kind of the whole nature of the issue, is there are some things we can't take back once they happen in MS, and we try to avoid that scenario.
Well, Dr. Colquitt, Dr. Hunter, I want to thank you so much for being here at this NeuroNexus event hosted by Advanced Neurosciences Institute.